Welcome to The Explainer. Deciding who gets a liver transplant is, without a doubt, one of the toughest calls in all of medicine. So today, we're going to walk through this whole high-stakes selection process, creating a really practical guide for all you medical trainees out there on the front lines. So let's start with the big question, right? Who actually qualifies for a new liver? This is something that transplant teams wrestle with every single day. And it's not just about finding the sickest person. It's about figuring out who has the best shot at a successful, long-term outcome with this precious, life-saving organ. The decision to transplant is never, ever simple. You're constantly weighing these massive risks. I mean, we're talking about huge surgery, the possibility of the original disease coming back, a lifetime of immunosuppression. You're weighing all of that against this incredible potential reward, a whole new lease on life. It's a constant, careful balancing act. To help make sense of it all, here's what we're going to cover. First, we'll dig into that fundamental risk-benefit question. Then, we'll look at the specific reasons someone would get a transplant. After that, we'll talk about the deal breakers, walk through the intense evaluation process, and wrap it all up with the key takeaways you really need to know. All right, first up, let's really get our heads around the core philosophy here. Look, this isn't about finding some kind of perfect candidate. It's about finding the patient for whom a transplant, with all its challenges, really is the best path forward. You know, there's a common misconception that a transplant is a permanent cure. But for a lot of conditions, the underlying disease can actually come back in the new organ. And that's why we have to be so sure that the benefits just dramatically outweigh all those risks. This quote, it perfectly frames the entire way we think about this. Okay, this chart tells a really powerful story about what's happening in public health. Of course, hepatitis C and liver cancer are still huge players, but look at the rise in transplants for alcohol-related liver disease and something called NASH. It really shows a major shift in the landscape of chronic liver disease. So if that risk-benefit analysis points towards transplant, what are the actual clinical situations that kick off an evaluation? Let's dive into the key indications that start a patient down this very long and complicated path. Generally speaking, candidates fall into one of these four big buckets. You've got acute liver failure, which is a flat-out emergency. Then there's cirrhosis, which is by far the most common reason. And then you have cancers that are stuck in the liver and some specific metabolic diseases where the liver is actually the root cause of a body-wide problem. Now, if you're a trainee on the wards with a patient who is decompensated cirrhosis, this is the number you need to have in your head, the MELD score. It's this powerful objective calculation. It looks at bilirubin, creatinine, and INR, and it predicts 90-day mortality. It's really the main tool we use for prioritizing patients on the wait list. And here it is. This is the magic number 15. A MELD score of 15 is generally the tipping point. See, at this level of sickness, the risk of dying from their liver disease soon becomes high enough that the huge risks of transplantation start to look justified. The whole evaluation process usually gets going once that score starts creeping above 10. But, and this is a big but, the MELD score isn't perfect. It just doesn't capture the mortality risk for every single condition. Because it's based on those lab values for liver and kidney function, it can totally miss things, like the really severe oxygen problems you see in hepatopulmonary syndrome. And that's exactly why, for these specific diseases, patients get what we call exception points to bump up their score to a level that truly reflects how sick they are. Now, for liver cancers, the goal is different. The goal is a cure. And that's why the eligibility is defined by these incredibly strict criteria. You might hear them called the Milan criteria for HCC. Basically, the amount of tumor has to be very limited to make sure that when we transplant the liver, we're taking out all of the cancer. That gives the patient the absolute best shot at long-term disease-free survival. Okay, let's flip the coin. Even if a patient has a clear reason for a transplant, what could stop them from getting one? This brings us to the super important topic of contraindications. It is vital to understand the difference between these two columns. On the left, you've got the hard stops, the deal breakers, things like an infection that's out of control or a cancer that has already spread. These things make the surgery just way too risky. Now, on the right are what we call relative issues, things like advanced age or severe obesity. They don't automatically rule someone out, but they do mean we need to have a much more careful, case-by-case discussion about the risks involved. So, once a patient meets those initial criteria and doesn't have any of those hard stop contraindications, they enter what I like to call the evaluation gauntlet. and it is an incredibly thorough process designed to uncover any and all hidden risks. You can almost think of this workup as a four-part audit, and it's designed to answer one single question from every possible angle. Can this patient not only survive the massive physical stress of the surgery, but can they also thrive in the years that follow with a really complex medical routine? And here's just a little snapshot of what that audit looks like. We're testing the heart's ability to handle the surgery with stress tests. We're screening for dormant infections like TB that could become life-threatening once we start those lifelong immunosuppressant drugs. And just as important, we're doing a really deep dive on their psychosocial situation to make sure they have the support and the stability they need for long-term success. At the end of the day, every single test, every single consultation, it all shares one unified purpose: proactive problem solving. It's all about finding and fixing any issue that could possibly compromise the success of the transplant down the road. Okay, we have covered a ton of ground, so let's boil it all down to the most important, high-yield points that you should absolutely carry with you on your rotations. Seriously, if you remember nothing else from this whole explainer, remember these four things. First, always think risk-benefit, not just cure. Second, know that the MELD score drives this whole process and that 15 is the key number. Third, remember MELD doesn't tell the whole story. Always be on the lookout for those exceptions. And finally, appreciate that pre-transplant workup for what it really is: a full-body audit of a patient's ability to succeed. And that leaves us with one last thing to think about. As medicine keeps advancing, with better heart treatments, new cancer therapies, more effective ways to manage obesity, which of the barriers that we see today might just disappear tomorrow? It's a field that is always evolving, and it's constantly challenging us to rethink the limits of what's possible.